Thank you so much. So it's really, really, truly my pleasure to thank Lionel Bercovitch for joining us today as a faculty. So Lionel is really one of our major leaders in pediatric dermatology, and also has a lot of overlaps with San Diego and Rady and such. So Lionel is a professor of dermatology and head of pediatric dermatology at Brown University and Hatfield Children's Hospital. He's a native-born Canadian, and actually, after he graduated medical school from Manitoba in Winnipeg, that school got renamed to be the Rady School of Medicine, similar to the Children's Hospital here being renamed Rady Children's Hospital. That family being philanthropic in multiple countries. So we get to wear similar paraphernalia with the Rady name on it. And then Lionel then went on and actually was a resident internal medicine at Mass General, and then did his dermatology at Brown. He is co-editor in chief of pediatric dermatology. Alona Fried and I were very happy to turn it over to Andrea Zaglin and Lionel, and they've done an incredible job with the journal. He's also editor of Dermatoethics. He has 2 of his 4 children live in San Diego, and he also is medical director of the PXC International Group, which is also based in San Diego. So other than a non-COVID years, it's nice to have Dr. Bercovitch come out and visit with us both as a friend personally, and it's great that we have him speaking, but unfortunately virtually today. And so Lionel, welcome, and I guess we'll be discussing. So Lionel is well known in ethics and dermatology. He's co-editor of Dermatoethics. It just had its 2nd edition printed. I guess we're going to hear today on pandemic dermatoethics. You're muted, Lionel. Lionel, yeah, you got it. I think you're muted.
Unmute. Oh, I didn't realize
there
that
we
was
go.
Okay, I'm unmuted now?
Yep.
Good. All right. Okay, well, thanks for that introduction. And I do have, very close fond feelings for San Diego. In fact, my first job after I finished my Mass General medical residency was at UCSD, but I had just met my wife and I decided not to leave Boston at the time. So there are numerous ethical issues that impact dermatologists relating to the COVID pandemic, but in the interest of time, I'm going to concentrate on 2, the ethical and professional obligations of physicians during pandemics and epidemics. And I apologize to the members of the U.S. Navy who are attending, because for you, this is probably not an ethical dilemma at all, and the ethics of mandating vaccination for healthcare workers. So as Larry mentioned, I am a graduate of the Rady College of Medicine in Winnipeg, and actually Max Rady, after whom that was named, was the father of Sam Rady, who named the Rady Children's Hospital. So it's they were a prominent family, and still are in Winnipeg and in San Diego both. Unfortunately, the weather in Winnipeg is nothing like that in San Diego. I have no relevant disclosures. I do get an honorarium as co-editor-in-chief of Pediatric Dermatology, and I made $12 in royalties from the first edition of Dermatoethics last year, and so far I haven't seen a penny this year for the 2nd edition. So I guess the moral of the story is, if you're going to monetize your passions, probably better not to do it in medical book writing. So first, a little bit of historical perspective. So physicians don't have the greatest reputation in terms of past epidemics. This goes back to the time of Galen and the Roman Empire. The Black Death descended on Europe. This was the bubonic plague in the mid-14th century. And I'm quoting from some sources, writer after writer lamented the avarice and cowardice of doctors in times of plague. Physicians all over Europe appear to have fled from incurable disease and incurable patients alike. Or this 14th century advice to medical students: If you are asked to treat a patient with no chance of recovery, say that you will be leaving town shortly and cannot take the case. It's probably still good advice. Nearly all physicians withdrew out of fear and terror. Some of the doctors who did not actually leave the city locked themselves in their houses and refused to come out. In fact, the city-state of Venice actually passed a law revoking the citizenship of physicians who left town during the Black Plague. Flee early, flee far, and return late. Plague came to the United Kingdom again for the second time in the mid-1600s. And even Thomas Sydenham, who was regarded as the quote-unquote English Hippocrates, fled London until 1668, and along with many wealthy Londoners, much to the consternation of those living in the hinterlands who did not want the Londoners moving in. One of his contemporaries wrote that able persons might have saved me this labor if they'd not been timorous and like foxes in a storm run to the next burrow. Every man that undertakes to be of a profession must take all parts of it, the good and the evil, the pleasure and the pain, the profit and inconvenience altogether, and not pick and choose, for ministers must preach, captains must fight, physicians attend upon the sick, etc. This is Benjamin Rush, who is best known as the physician signer of the Declaration of Independence, but is also known for having stuck out the yellow fever epidemic in late 1700s, early 1800s in Philadelphia, and actually was affected by yellow fever himself. And his altruism and that of some of the physicians who did stay with him eventually spilled over into the early AMA. And although there had been codes of ethics for millennia in medicine, the first time the codes of ethics ever addressed the question of service during epidemics was in the AMA first edition Code of Ethics in 1847, which stated that when pestilence prevails, it's the physician's duty to face the danger and continue their labors for the alleviation of suffering, even at the jeopardy of their own lives. So I'm going to come up with a couple of cases. I'm sure some of the residents who were doing consults during the the recent surge in San Diego and last spring probably have felt a bit like this doing their consults with all their PPE on. So case one, a 70-year-old male who was admitted to the Hillcrest ICU with confirmed SARS-CoV-2 infection develops generalized spreading tender erythema and bullae. An in-person dermatology consultation is requested. The second-year derm resident on call refuses to do the consult in person. I didn't sign on to die. And her co-resident, during the surge, a second-year dermatology resident is notified that he is going to be redeployed to the COVID ward due to a shortage of medical health staff. He refuses, stating that his contract only specifies that he carry on the duties of a dermatology resident. I also didn't sign on to die. Is this ethically justifiable? And this was an issue, I'm not sure whether it was an issue at UCSD. It was definitely an issue in New York. It was an issue along most of the East Coast during the first surge between last April and last June. So this isn't just a theoretical or hypothetical exercise. This is a real phenomenon and a real concern. This is Adeline Fagan, a beautiful and intelligent 28-year-old who had not been an intern at HCA Healthcare West in Houston for 1 month when she was infected with SARS-CoV-2 pneumonia and never made it off the respirator, having passed away in September 19th, 2020. And as you can see from this slide, although the death rate in the over 70 group is quite high, ranging 8 to 15%, even in the 20 to 49 age group, in which many of our residents fall, it's not zero, it's 0.32%, which is still 1 in every 300 or 400. So it's something to be concerned about. So deploy is a term that I'm sure all the military are familiar with, and we're most familiar with hearing it as deploying troops to a war zone, Afghanistan, Middle East. Can be used to indicate optimizing placement of strategic assets, which I guess is probably partly what it entails here. But it was argued, and still is, that deploying residents without adequate PPE and training puts them at unnecessary risk. And unlike military deployment, when residents get deployed, they don't get hazard duty pay. They don't have paid life insurance, disability or death benefit if they die in the line of duty or become injured or disabled in the line of duty. In fact, the Residents Association at NYU demanded this of the medical center there and were denied back in the spring. So as I said, this is probably not something that I think people in the military would definitely take this for granted, and it's not something that we would consider questioning but it was widely became a widespread issue in New York back in April and May and elsewhere in the country. In fact, in March and April 2020, 75% of programs had at least one resident redeployed. 27% of residents reported being redeployed in New York City. And in some programs, 40% had more than 1/3 of the residents redeployed at once. Half of them went to ICUs, 30% to hospital floors, and 14% to the emergency department. In our own program, the residents were all who stayed to work were all eventually deployed to COVID units, and there were but fortunately, there were only 2 or 3 at a time. They rotated them, so we were never too short of residents. At that time, half of PD's surveys said their residents had to work with suboptimal PPE. And back in the spring, that was the case. I mean, there was a real shortage of N95 masks. Then N95 masks got stretched as much as they could. So one of the ethical issues is that there's a lack of autonomy in hospitals where redeployment was not voluntary. Residents really did not have a say. And, if you're not happy with UCSD having deployed you, you can't just sort of say, well, I'll just transfer to UC Irvine or UC Davis or UCSF or UCLA or wherever. You're really pretty well stuck in the program you match to. So you don't have a lot of leverage. As I said, residents in dermatology had no say in where they were redeployed. And also hospitals have a reciprocal social contract, and I'm going to talk about that later on, but the reciprocal social contract requires healthcare institutions to provide adequate PPE, and such as N95 masks, which were being reused for way longer than were considered safe. And at one time were only available for known high-risk procedures or contacts. They were treated like they were platinum. And this was a fairly common occurrence last spring, probably not so much now. So the basic dilemma is that of the duty to treat versus one's self-interest or self-preservation. So the duty to treat can be subdivided into 5 components: professional oaths and codes of ethics, contractual consent, implied consent, special training, and social contract. We'll go over these one by one. And the conflicting obligations of self-preservation include, are there limits to the duty to treat? Where does the duty to treat end and heroism start? And where does heroism end and martyrdom start? And the obligations of society to healthcare workers and the obligation of healthcare workers to themselves and to family. So I think you probably at one point have taken a professional oath, whether it was at graduation or white coat ceremonies, depending on whether you are old enough to have not had a white coat ceremony. They're not really uniform between schools and disciplines, and they're really more of an altruistic or moral commitment. They're not really a contract or a fiduciary obligation to a specific patient, and they're not legally binding. Or to quote Mullen, who's one of the seminal authors in this field, nobility may be wonderful, but we don't want to rely on a vague virtue in planning for a pandemic. So in 1912, we saw the earlier wording of the AMA Code of Ethics. In 1912, the AMA changed the wording to, when an epidemic prevails, a physician must continue his labors for the alleviation of suffering people without regard to the risk to his own health or to financial returns. And this was the wording that was in place in 1918 during the flu epidemic. In 1957, the AMA removed all statements regarding epidemics. And the Code of Ethics now stated a physician is free to choose whom he will serve. In an emergency, however, he should render service to the best of his ability. Having undertaken the care of a patient, he may not neglect him. Sorry for the paternalistic sounding he, but that's the way medicine was back in that time, and that's the way the Code of Ethics read. So fast forward to the 1980s, and that was a very interesting time because in many ways it was just like the epidemics of past centuries. Initially, little was known about the cause of AIDS. There was no test, there was no treatment. There was a lot of fear. There certainly was not, the President Reagan at the time was not supportive at all of AIDS research. And many dermatologists and other physicians shied away from treating patients with AIDS or refused to treat patients with AIDS or do biopsies, for example, and would even not treat healthy gay males because of concern about AIDS when it was regarded as a particular affliction of the gay male population, especially in New York and San Francisco. So in 1992, the AMA finally dealt with this, stating that physician may not ethically refuse to treat a patient whose condition is within the physician's current realm of competence solely because the patient is seropositive for HIV. Persons who are seropositive should not be subject to discrimination. So you could substitute the words positive for SARS-CoV-2 by PCR to update it for today. And you've noticed that they actually removed the words he from physician. Now the physician was neutered or neutral. In 2002, the AMA joined other physician groups in stating that we commit ourselves to apply our knowledge and skills when needed, though doing so may put us at risk. But this wasn't universal. This is interesting. This is the Code of Ethics from the Nigerian Dental Council and Medical Council Code of Ethics in 1995. Healthcare workers are not penalized for failure to provide care and may ostracize patients with symptom of Ebola virus disease. The AMA Code of Ethics is essentially the same, the AAD is essentially the same as the AMA. It states that dermatologists should not discriminate against the class or category of patients or refuse management of patient because of medical risk, real or imagined. So let's move on to contractual obligations. Consent can be expressed or contract-based as an employment agreement, but that's fairly uncommon medical practice. It might be the case for a medical center employed infection control officer or emergency physician or infectious disease or critical care physician, but I suspect even those, I think the consent is so strongly implied that it needn't be stated in a contract. So apropos what Nigeria had to say about Ebola virus, in 2014, when there was concern that the West African Ebola epidemic might reach the US mainland, the state of Rhode Island, where I practice, Department of Health issued regulations stating that the licensed healthcare professionals in active practice are obliged to treat and care for Ebola patients while minimizing the risk of Ebola transmission to self and others. Failure to do so is a potential breach of licensing laws for healthcare professionals. They haven't updated this for the current pandemic, but I think that that hasn't been necessary, at least not this year. So implied consent is something that you assume as part of your job description. The risks of infectious diseases are an integral part of medical practice, and you don't have to expressly state or accept them. Or to quote Mom, you get on the fire truck when the alarm sounds. But unlike firefighting or police work, medicine is much more specialized, and a dermatologist or dermatology resident might argue that she did not consent to the risk of treating infectious diseases such as COVID-19 or Ebola just by virtue of having chosen dermatology as a specialty, and may have even chosen dermatology due to its low risk. However, of course, there are many highly contagious viral disorders with skin manifestations. There's probably about 150 pages in Bologna just listing those and describing them. And in a tertiary center, one should expect potential exposure and that you are going to have derm consults that may pose some personal risk. Some have argued that just because you haven't dissented or in your employment agreement or in agreeing to work doesn't mean that you've assented, and that it would be counterproductive if the only means for dissent would be not to become a healthcare worker at all. And indeed, some physicians and healthcare workers may not possess the training to fully understand and control the risks. I mean, somebody in ophthalmology may not have the same background or training as somebody in infectious diseases or has worked on a medical ward or in an ICU. So we can't assume necessarily that all healthcare workers satisfy conditions for implied consent by virtue of choice of profession. Then there's the special training argument. This argument implies that by virtue of special training, professionals receive, they have a special duty to provide care, both because of their expertise in knowing how to reduce risks, and failure to do so could be considered immoral. But just having special, because you have special training doesn't necessarily justify a special duty to take on greater risks. So there are arguments on both sides of the issue, as often is the case with ethical dilemmas. Then there's the social contract, which states that you as physicians have prestige, a higher income, exclusive scope of practice, reduced competition, and the ability to self-regulate. Well, that may have been the case 20 years ago. I think it's certainly less the case now, but still, we are doing pretty well compared to most people. And medical education, especially graduate medical education, is highly subsidized, often by taxpayers. Physicians and healthcare workers have greater access to PPE, treatment, vaccines, than non-healthcare workers. And the argument goes that all these benefits, especially exclusive scope of practice, oblige physicians to assume a greater risk and create a duty to treat. So the counter argument, as this T-shirt goes, I want to renegotiate my social contract, is that we've all accepted some benefit from society, whether we've gone to law school or whether we've gone to an undergraduate institution like UCLA or UCSD or any state university, and yet we do not believe that it creates a special duty. And then we have some professionals, such as nurses and paramedics, who receive far fewer benefits than physicians, but may be required to assume greater risks along with the duty to treat. So accepting the social contract argument means that either different groups have different duties to treat, or we accept that the injustices that are related to these disproportionate risks. And then there's a different type of social contract. This is the sort of reciprocal contract, well, not this is the solidarity argument, where you have a contract with your fellow residents, your fellow attendings, and your colleagues to share the burden. If one resident refuses to do the consult because of fear of risks, those risks will have to be assumed by another resident unless an exception is made by the attending to do the consult by yourself. So is one resident's life worth more than another's? One could argue, of course, that if there is that much risk, that maybe there's no point in diffusing the risk by having two people go, and why not just have the attending do it? The decision potentially creates bad precedent for the next time the situation arises and can create resentment within a program, which could have long-term harm for the program. And then what would happen if everyone then refused to do the consult because one or two people refused? So let's move on and look at some of the conflicting obligations and try to tie it all together. First of all, are there limits to the duty to treat? So we all have a moral duty to assist those in dire need if we can do so at minimal risk to ourselves. So that includes calling 911 in a serious emergency, performing a Heimlich maneuver in a restaurant, doing chest compressions in case of a cardiac arrest at the airport or in the hallway, or throwing a life preserver to a drowning person. You don't have to have a special relationship with that individual, be their doctor or be their lifeguard or whatever. And then there are special positive duties. And these depend on a special relationship between the aider and the aided that forms the ground for the duty. And that's probably more relevant to this situation. So this could be the lifeguard and the swimmer, paramedic or patient. There is an expressed or implied consent as part of your job. So this can obligate a person to take on greater risks than in a general positive duty, where you really minimize the risk to yourself. But there are limits to that risk. A firefighter doesn't have to enter into a collapsing building. A paramedic doesn't have to run onto Interstate 5 or Interstate 8 and risk getting killed by a speeding car in the breakdown lane. So are there limits to the duty to treat? Well, the duty to treat cannot be regarded as absolute. There's a term called supererogatory, and that's where professional duty begins to wane and the act of providing care is morally good but not strictly required. This is going above and beyond what you would expect from professional duty. And just how to determine what those risks is the problem. So military personnel are aware that when they're enlisted or conscripted, they have no choice but to follow the orders of their superiors into combat, and often at risk to their own lives. But even a virtuous, ethical, and altruistic physician might not be willing to die for a patient and may refuse to serve. And then there's the reciprocal contract, which we referred to earlier. Affirming the healthcare worker's ethical duty to care imposes a correlative duty on healthcare administrators and senior physicians to quickly develop and deploy procedures to maximize the safety and frontline physicians and nurses. I'm quoting Ezekiel Emanuel, who Rahm Emanuel's brother, who's a professor of medical ethics at Penn. And I think for the most part, healthcare institutions did that and have done that, but this included things like providing a safe and optimal environment and PPE as possible. And I think most institutions have now done that. Although getting the N95 masks is certainly something that varied between places. Support and fulfilling childcare and family obligations while serving might not be an issue for an episodic derm consult, but certainly would be when physicians have been taken away from home for sometimes days at a time during pandemics and epidemics. Compensation for risks, I don't think that's been an issue in most places, although I have to say that Rhode Island Hospital did use some of its PPP money or whatever grant money they got from the federal government to bonus the residents and staff who worked throughout the epidemic. Provision of priority to access, priority of access to optimal medical care becomes infected. I think that's been the case in most places. Meaningful compensation for one's family if one dies of work-acquired infection. I don't think that exists at least for residents in most institutions. Humane treatment of healthcare workers and family during an outbreak. Again, that's something that's probably not true of every institution. And priority for vaccination when available. Well, that certainly has been the case across the country. So on the one hand, it's been argued that firefighters don't get to choose their fires and police don't get to choose their patrols, and therefore professionals must place their duties ahead of their own comfort and safety. But professional duties have limits. Physicians and other healthcare workers have an obligation to care for themselves and to their families. And one can question whether the interests of spouses or children or parents should be held hostage to professional duty. So equating the duty of care with altruism creates moral conflicts between the various parties to whom the physician owes care, to his or her patients, oneself, and to one's family. Learning to care for oneself can be an ethical act as well. Physicians have an obligation not to become patients and not to become sick themselves in taking care of others. And fear and anxiety about becoming infected is very real. I mean, we read the same newspapers. Well, we might not read the New York Daily News, but just the same, we get exposed to the same sensational news that everybody else does. Or to put it differently, physicians swim in the same social ocean as their fellow citizens and are subject to the same set of fears as everyone else. So is there a resolution? We have here the conflict between the duty to care grounded in professional codes, societal expectations, and the duty not to unfairly burden one's colleagues, favoring the obligation to do the consults and go to the COVID ward versus the obligation to preserve one's own health and one's duty to one's family. and which are in and of themselves strong conflicting obligations, and certainly very realistic. To quote the title of one paper, what if they gave an epidemic and nobody came? What if every derm resident or attending refused to do the consult to provide care for the patient? Ideally, it should be possible to protect the healthcare worker from the risk of infection with proper PPE and environmental measures, minimizing the risk. Early on, this wasn't always the case, however, and it may never be possible to completely eliminate risk, even with the best of intentions. During the Toronto Sars outbreak, there were physicians and other healthcare workers who died. There have been many healthcare workers who've passed away during COVID-19, including several physicians, thereby creating an irresolvable dilemma for many. So there's no professional obligation to be a hero or a martyr, but there is an obligation, which I think we will all agree to, that we have an obligation to do the job that we've signed up for, to utilize our professional skills in a beneficent way in an urgent situation when called upon, and not to unfairly burden one's colleagues, and to do so in the safest possible way. But it's not always as straightforward as this when one is confronted with a dangerous and infectious disorder without adequate protection or adequate training. So I'm going to quote from one of the Dermatoethics Journal Club pieces in JAD in June. The bottom line is to fulfill it, but this is in response to a resident who wondered if he should get a lawyer to enforce his contract and not be deployed. The bottom line is that to fulfill your obligations as a professional in the House of Medicine, ensure medical care is delivered to those in need, help patients, and do no harm. And for your own dignity, do not call a lawyer, grab your stethoscope, and do the right thing. So that's one bottom line way of looking at it. But like many ethical conflicts, there's often no right or wrong. There are good arguments on both sides, and very often one has to make a personal decision. But these personal decisions can have significant consequences on one's fellow workers and one's patients. So I want to just move on to the second subject, and then we'll have time for discussion afterwards, because I'm sure there are a lot of opinions. And this is the question of whether vaccines should be mandated for healthcare workers. There's been a lot of press in the last 2, 3, 4 weeks, now that vaccines are becoming more readily available, whether vaccines should be mandated for the entire population. And we'll sort of touch on that, but it's not really there is no vaccine that's mandated for the entire adult population in this country. And in fact, vaccine mandates such as for childhood, for children and attending school, are really state by state. They're not federal. But healthcare workers are a special class when it comes to vaccination requirements. So we'll spend more time talking about that. I'm sure you've seen some pictures like these, if not these same pictures, over the last year. You notice the one thing they have in common is they all seem to be draped in the stars and stripes, as if they somehow are equated with patriotism, which I think could not be further from the truth. I found the one that particularly interesting was the one on the bottom right of "My Body, My Choice," because this is so antithetical to the past administration's view of what really "My Body, My Choice" was originally entitled, or at least initially stood for. So antipathy to vaccine mandates is not new. In England in the 1860s, Parliament passed the Vaccine Act that mandated smallpox vaccination to prevent outbreaks that were popping up as people were not getting vaccines. And anti-vaccination societies and publications sprouted all over the country. This is an example of an anti-vax group called the Cowpox, or the Wonderful Effects of the New Vaccination! Publication of the Anti-Vaccinative Society. And there's a French expression, something to the effect that the more things change, the more they stay the same. And here are some clippings from 1918, the flu epidemic, I think mostly from the San Francisco Chronicle. There were the same feelings about masks then as there exist now in various pockets in the country, especially the one on the bottom right, 3-shot and struggle with mask slacker. Blacksmith strikes health inspectors striving to enforce order. And just like they've had people serving in Walmarts and stores who have been stabbed by people who refuse to put on their masks. So things haven't really changed that much. Human nature is the one constant that we can kind of depend on from century to century. So these are recent facts. This Kaiser Family Foundation poll, Washington Post poll, was published about 2 to 3 weeks ago. The data mostly was gathered in January and February, so it's pretty current. More than 4 in 10 healthcare workers have not been vaccinated. In fact, they were quoting some of the remarks of people who would not get vaccinated, who said, "I'd quit if work told me I had to take it." And we'll touch on that subject later on. About 30% of the people polled said they hadn't been vaccinated, or they hadn't decided, or they did not plan on being vaccinated. 19% were scheduled or said they planned to, and 52% actually had at least one dose. If you look at this bar graph over here, you can see that the vaccination rates were the lowest among African-American healthcare workers and women and those who are working in patients' homes. And so you can see here 57% of white, 44% of Hispanic, and 39% of African-American healthcare workers in the US were vaccine hesitant. 26% of home healthcare workers had received one dose of COVID vaccine. And that's deplorable. I mean, I have a personal feeling about that. My mother-in-law was infected with COVID in April 2020, having been infected by a home healthcare worker that was, assisting with her care, and died 5 days later after having lived independently her entire life up to age 97. So that's something that's really significant. And even in nursing homes, where we know the mortality is high, there's a 50% hesitancy rate. And it's not just healthcare workers. Massachusetts state police officers were offered COVID vaccines at work. Nearly half declined to get them. Prison workers, this is also from the Boston Globe, and there were tremendous numbers of deaths in the Rhode Island and Massachusetts prisons, and I think this was the case all over the country. And despite this, prison workers were refusing to get the vaccine. We could get into the politics of this, but I'll skip over that now. I think you can read between the lines. Even firefighters and military recruits. There was an article in the New York Times, I think a week and a half ago, that 75% of young military recruits were declining the vaccine. The single greatest factor that correlated with whether one was vaccine hesitant or vaccine anti-vax or not was one's political leaning. 49% of GOP-leaning men said they would not get one of 3 federally approved coronavirus vaccines, whereas only 1/8 as many, 6% of Democrats said the same. That's really, just gives you an idea of how polarized our society is. In not just, it obviously starts with politics, but it's deeper than just politics. Of course, Andy Borowitz thought the best way around this was to have Obama persuade Republicans to take the vaccine by urging them not to. So the reasons that people have for refusing vaccines are very telling, because it tells us where we need to really be directing our education and our information. A lot of vaccine hesitancy is based on misinformation or information that's gleaned off social media, where a relatively small number of people and sites are really driving most of the misinformation. Something like 51%, and numbers ranging from 40 to 67%, were concerned that they might get COVID-19 from the vaccine. I mean, that is just totally false, but you can see where that information or belief would come from. I mean, not many people have the background to understand the mechanics of RNA vaccines or to know what goes into a vaccine. Many felt they would miss work if the side effects made them feel sick and they could not afford to do it. Nearly half thought they would have to pay out of pocket to get the vaccine, despite the fact that I thought it was pretty well publicized that the vaccine was free. And close to half felt they couldn't get the vaccine from a place they trusted. Of those who, 50% of those who were polled among Black adults were concerned that the vaccine, they were not confident or at all, or not too confident that the vaccine had been adequately tested among people of their own ethnic or racial groups, and about 34% of Hispanics. So that's something that needs to be better publicized as well. So mandating vaccines for the general public is something that's been written about for many, many years, especially going back to flu vaccine. And the ethical literature, discusses what kind of conditions you need. There should be a grave threat to public health, which I think we can check off that box. The vaccine should be both safe and effective. Well, I think it's pretty effective, but whether it's safe is something that has not yet been fully signed on by the FDA. Although I think it's pretty safe based on what we know so far. That mandatory vaccine should have a superior cost-benefit profile compared with other alternatives. Well, we don't have any other alternatives that would not completely shut down the economy, so I think that one can check off that box. And the level of coercion should be proportionate. I mean, you can't put people in jail for refusing to get a vaccine or to fine them $5,000. There has to be some kind of, if you're going to use, you better to use a carrot than a stick, and if you're going to use a stick, it shouldn't be a baseball bat or a cat o' nine tails. Oh, I'm not sure how many of you read Hebrew, but this is a recent Israeli app. It's had some press in the last week. Those who've had their 2 vaccines in Israel get a green pass, and this electronic or digital pass enables them to go to the gym, go to concerts, stay in hotels. And pretty soon it's going to, when the restaurants open, will allow them to eat indoors in restaurants, and go to movie theaters and attend other public events. And there's still, and the European Union is considering something similar. The problem here, and there's been a lot of criticism, is that number one, there are privacy concerns, and number two, that it discriminates against younger people because many younger people have not yet been able to get the vaccine. So I'm not going to go into it in any more detail, but this is today because it's beyond the scope of this talk, but this is something you're going to hear a lot more about soon. So putting in terms of the ethical principles that we were all taught in medical school, there should be beneficence. The problem should be significant, and the vaccine should be effective in addressing it. I think we can agree to that. Non-maleficence, the risk should be low, and I think the evidence seems to indicate that right now. Respect for autonomy, meaning coercion only if necessary and should be minimized. Well, the word mandate and the word autonomy are really mutually exclusive terms. And justice, the benefits and burdens should be fairly distributed across the population. In other words, equitable access means equitable immunology or immunoequity. I mean, there really should be equitable access within communities and equitable testing and so forth. So I think let's consider healthcare workers. The major barriers to mandating vaccination against SARS-CoV-2 include the fact that the vaccines have only been approved under emergency use authorization, or EUA, not under the full FDA biologics license application. The possibility exists that individuals would distrust the mandate and regard vaccination under EUA as ongoing medical research or potentially unsafe. Or what some people are doing is just using it as an excuse, period. It's not known if the SARS-CoV-2 vaccine prevents infection and transmission or just the disease, and hospitalizations. Long-term safety data are unavailable, and duration of immunity still is unknown. And then, of course, the infringement on autonomy. But healthcare facilities have a different obligation. They have an obligation to provide a safe environment and effective control for staff and patients. Most healthcare institutions, in fact, I don't know of any that don't, already mandate flu vaccine for their workers, as well as having demonstrated immunity against other infectious diseases. I know that I started working here at Brown, the hospital, even though I said, oh, I had measles and mumps and chickenpox and rubella as a kid, I didn't have to be vaccinated. They weren't, in God we trust, all those show us their antibodies. I had to get tested to make sure I demonstrate serologic immunity. Although healthcare workers in the hospital can refuse flu vaccine, they have to work masked the entire winter, and there are very few who have refused. But physicians can't renew their privileges without getting the flu vaccine. Vaccines prevent hospitalizations, they prevent disease and workforce shortages, and they preserve healthcare resources. And it's what people expect from healthcare institutions when they go there. So the EEOC has issued guidance that companies can require employees to be vaccinated against SARS-CoV-2 and bar an employee from the workplace for refusal. And the only grounds for refusal are religious exemptions and disability related. So to put it in another way, no jab, no job. So by medical exemptions, they mean disabilities covered by the ADA, including being immunocompromised, but only if these don't pose an undue hardship for the employer. Accommodation should not pose an undue financial hardship for the employer. What may be reasonable for a large corporation may not be considered reasonable for a mom and pop shop. So institutions like Lifespan Healthcare here or UCSD or other large institutions have different mandates for accommodations. Religious belief is separate from personal or political beliefs. It has to be sincerely held and need not be based on a theistic religion. Can be overridden, however, if it creates an undue hardship for the employer, including jeopardizing the health of other staff or customers or patients. In some cases, it may be permissible or practical to make accommodations to have the worker work remotely or wear a mask at all times, but that really depends on the individual employer. So legal mandates among populations that don't widely support vaccination can be counterproductive because they override personal autonomy, but legal mandates in high risk or healthcare settings are likely to have public support and certainly patient support. When we have longer term safety data and FDA approval, mandates may become part of a comprehensive public health strategy to return to the pre-pandemic state, but we're not there yet. So, autonomy and beneficence and non-maleficence are cornerstones of patient-centered Western bioethics, but we're in a public health and economic emergency in which public health ethics takes precedence. To quote Henry Ford, the dean of the Miller Medical School, University of Miami, the welfare of the community and our patients trumps the autonomy and welfare of individuals in the state. We must do the most good for the most people, the so-called utilitarian approach, and save as many lives and life years as possible. And once the FDA has approved the COVID vaccines as safe and effective, absent medical indication, they should become mandatory, at least for healthcare workers. We've lived through an unprecedented year of economic hardship and just total disruption in our lives and psychological distress. And the bottom line is vaccine hesitancy and skepticism are costing lives, whether in the healthcare setting or in the community. So I think, at least in the healthcare setting, I think there's a strong argument for mandating vaccination. So that's all I have to say. And for those who did work through the worst of the SARS CoV-2 epidemic, I give you thanks. And now we want to have some discussion and questions and answers. I'd be happy to open the floor.
Yeah. Thank you, Lionel. That was incredible. As I expected, it was incredibly up to date and scholarly, but also, I mean, how you pull back to the history and the I guess recurrent themes of attempting to.
I'm sorry, I'm having a hard time hearing any of this. I don't know whether I can make the volume higher or not. I just.
Okay, hold on. Let's see if I can people hear me?
Yeah.
Mm-hmm.
Okay, I'll speak more clearly. I said, thank you, Lionel. That was incredibly up to date, but also scholarly. And I loved how you brought in the history into it to show how we've had, we wrestle with these issues again and again. It's not the first time it seems that we face these issues. Certainly we don't mandate presently vaccines for employees at the Children's Hospital, and initially we had a lot of concern from our staff in dermatology. 60% had stated that they weren't going to get vaccinated. But it didn't take much, just straightforward discussion with them to move almost all of them, recognizing that they were at a different risk in relationship to, a different risk working, and then of course in relationship to protecting their family. But it's some of the aggregate data is scary in terms of where we sit with people's concerns about vaccines. Happy to take questions from the audience or comments.
Yeah, I'd love to ask a question. This is George Hightower. Context, I was reminded I'm a virologist by training and have more faith in some of the science than the average person. But one of the things I was hoping you could speak to is that those who understand this better than I do have a clear differentiation between vaccination rates, which some people have said are more due to access, hesitancy, and then attitudes that are anti-vaccine. And I think with the hesitancy, especially for certain ethnic groups, people have focused on existing unfair practices within medicine or disparities as one of the greatest reasons why there is that hesitancy. And I wonder, in context, if you could speak to how pandemics tend to fall along existing health disparities, and then what does that mean for the social contract going forward?
I think the problem is the microphones on this hospital computer are terrible. I think I heard you speaking, George, but I couldn't really hear exactly what the question was. Larry, can you repeat it, or maybe I bet.
I could try again. Can you hear me now?
Not bad. Yeah, go ahead. I'm sorry.
Oh, okay. Yeah, so what I focused on was the differentiation, and I said that people who understand this better than I do make between vaccination rates, which a lot of people are saying are related to access, hesitancy, and then anti-vaccine attitudes, right? And then folks have focused on, I think with some of the more sophisticated analysis that's come out, that a lot of the hesitancy, for example, among Black and Latino communities, actually result from existing disparities in medicine. So unfair treatment that people have experienced themselves at the hands of the healthcare system. And I'm wondering, in the context of your presentation, could you speak to how pandemics tend to fall along these existing health disparity lines? And then what does that mean for the social contract, right? Thinking about vaccines and thinking about the healthcare system going forward.
I think I heard about 2/3 of that, and I think it had to do with disparities in vaccine hesitancy. Am I hearing that correctly? And how to address it?
Yes, I put it in the chat as well. So George was saying there's both discordance in vaccine rates and populations. There's issues with hesitancy, and then there's just this sort of anti-vaccine temperament or vaccine concerns. And the second issue is, and then there's the issue of populations that just don't access care the same way, which impacts on
Well, absolutely. I mean, you can see that. California, of course, is probably the one state that has, especially well known for its pockets of anti-vax sentiment, but it exists all around the country and all around the world, and it's just probably become more of an issue in the 21st century than it ever was, even in past years. I can remember as a kid during the polio epidemic, we were so happy that when polio vaccine became available, that every parent lined up to get their kid vaccinated, because we couldn't go out in swimming pools in the summer because everybody was afraid that they would get polio from the enterovirus from the water, and that's and here we've got something that's preventing us from doing anything, and yet there's still a tremendous amount of anti-vax sentiment. You're right. Some of this is almost anti-vax for the sake of being anti-vax or being ornery or libertarian, and some of it is just deeply rooted mistrust in the healthcare system, which on one level and in many levels is justifiable. I mean, whether we're dealing with some of the really notorious things like the Tuskegee trials in the 1930s, or forced sterilizations in the 50s and 1940s, 50s, and 60s, or whether we're dealing with some of the prisoner trials in the 1970s that have become notorious in dermatology. I mean, there are many reasons why people may distrust the healthcare system, and these are not going to be undone very quickly. These require a lot of education and leadership from among the groups. I think that well-educated and trustworthy individuals like yourself or leaders in the Hispanic community are really essential for helping to reduce mistrust of the system and to try to win the trust of people who really have deeply held feelings about vaccination that are very different than libertarian views. These are not the same thing, and I think you and Larry hit the nail on the head. This is a very different type of vaccine hesitancy that we really need to address. This is not the same as Republicans versus Democrats. Yeah. I live in a very blue state, so I don't have to be nearly as careful about what I say here in Rhode Island, but it really is it's a huge issue here. I mean, the big issue, and the Boston Globe was very open about it, the big issue, or the big factor dividing those prison workers and state police from who got the vaccine from those who didn't, had to be their political leanings, and not a distrust of the system or a really scientifically rooted distrust of the vaccine.
So there's another question that expands on this. It said the Latinx population makes up 30% of San Diego demographics, but accounts for over 50% of COVID-related deaths. And recent studies have shown that while vaccine hesitancy plays a role in disadvantaged populations, access remains a primary issue. How would you say the issue of access plays into the social contract?
Yeah, that's a huge problem. It's a problem everywhere in the country. I mean, I think now that vaccines the supply is improving. I think, and I know, for example, in Rhode Island, the state has sent out a placard similar to what you put on your windshield for handicapped parking to every household in the state, stating how to get vaccine, how to get on the where to call, or what website to go on, and practically every possible way that, no matter whether you were technophobic or technologically able, that you would be reached. And I think that's one way they're addressing the inequities and trying to make access equitable. But for many cases, for the first, really until about the last couple of weeks, if you knew somebody who could make the call, who could stay on the phone all day, or if was technologically savvy or knew how to get the leftover vaccine at the end of the day, you had much more access, and it really was creating inequitable access for some of the elderly, for certainly for the economically disadvantaged, and for some non-English speaking groups in Rhode Island. We have a very large Hispanic population here, and people who don't speak English in Providence, and they were essentially, they definitely did not have equitable access. Yet they were suffering the bulk of the burden. And one thing that some states have done, Rhode Island did as well, is they early on they concentrated access and prioritized vaccinations not by age but by zip code. So Central Falls, which is 1 square mile, has 25,000 people, of which I think something like 15 or 16,000 live below the poverty line, and about 70% are Spanish speaking or Hispanic. They went in and took care of Central Falls before they took care of the rest of the state. And that's the kind of effort that needs to be done, but it's easier in a small state like Rhode Island than it is in a big state like California.
And the last question, in the interest of time, but it's a question was raised about from Dr. Schneider, who said it was a fabulous talk. He directs the inpatient consult service. I'm not sure if you can see the chats, but I'll read it to you. And so he's wrestled with some of the ethical issues, but one of the things he wanted discussed is consult stewardship, and they get consults which might not meet the threshold for acute inpatient issue. For instance, a minor flare of eczema, but they happen to be inpatient. And he's felt conflicted about entering the room or the need to do this. So what's your approach to that?
Well, I was fortunate during here at Rhode Island Hospital. The hospital took the issue out of our hands. They mandated that all non-essential consults that did not require our being in the room be done with pictures. So they were done virtually, and then eventually they got mobile. I guess they're like screens. They're like mobile iPads basically to allow us to do the consults virtually. So only the medical house staff who requested the consult and were already in the room would have to do it. So there, the medical house staff would take the photographs, and we would do our best. In fact, I would say that probably 95% of the consults we were able to do that way without any problem. And there were a few that we just really had to go in and see, and we limited those. So, and actually, we're still doing consults that way for some parts of the hospital, like the emergency department. But the thing is, we don't get paid for those unless they're done with the virtual two-way camera. We don't. Those consults are provided gratis, so we're not getting the income, but we're tying up our attendings and personnel, but we're providing the service, and so that's how we dealt with it. But it is a tough question. You really don't want to be going in for things that can be handled by looking at the media tab in Epic and looking at the pictures and reading the chart. Those things you really can take care of it. And a lot of those things can be taken care of as outpatients after discharge too. So we were able to do that too for some patients.
At this point, I think we're after the hour. Lionel, I can't thank you enough for your incredible lecture. It's very thought-provoking as well, and really, we've all dealt with so much over this, I guess, over a year now of COVID, and you did an incredible job at having us think through some of the issues. So thank you. I guess if other people do have questions that weren't answered, knowing Dr. Bercovitch, I'm sure he'd be happy to take those by email.
Yeah, I'm happy to answer anything by email. That's fine.
That's great. And
well,
thanks
very much. I can't wait to come back to San Diego in person. This is, I really missed getting to visit my kids and getting to visit you and getting to enjoy the beautiful weather.
Yeah. Well, we hope it soon. Dawn Eigenfeld, thank you for doing a great job marshaling the troops for the earlier part of the grand rounds. Everyone have a great rest of the day. Thank you.
Thanks so much. Take care.